Evening, everyone. My name is Kevin Malone, and I'm zooming in from Cleveland, Ohio, and I'm the moderator and presenter for this session tonight. This is one of the sessions in the AO Trauma and Hand North America online series entitled 3 Cases Fireside series. And today we are going to focus on fractures involving the base of the thumb metacarpal. First, we want to acknowledge and thank our chairman of the AO North America Hand Education Committee, Dr. Marco Rizzo, who has put in yeoman's efforts to keep us moving and allowing us to provide all of these great educational opportunities for all of you participants. And thank you to all of you who are signed in tonight to participate with us. Tonight, I am joined by 3 other excellent faculty members. Dr. Lauren Dutton from the Naval Hospital in Jacksonville, Florida, will be speaking with us, as well as our sage, Dr. Shyam Mudgal from Massachusetts General Hospital. And the 3 of us will each be discussing different aspects of thumb metacarpal base fractures. And then Heather Duyck from University of Vermont in Burlington will give us a therapist's perspective on rehabbing patients with these type of injuries to get them back to their desired level of activity. These are our conflicts of interest. None of these appear to have any issue with any of the material that will be discussed tonight. AO North America is an independent, nonprofit surgical specialty society dedicated to improving the care of patients with musculoskeletal injuries. AO North America does not endorse nor promote the use of any specific product or service of commercial entities, and any equipment or implants used or demonstrated in this course are truly for demonstration and teaching purposes with the intent to enhance the learning experience. There are CME credits available for you to claim, and you will be able to, if you have registered for all of these sessions, you have a total of 11.25 credits that you'll be able to claim. And after the series is over, which is a couple more months from now, you'll be sent a link for you to complete so we can get you those credits. Zoom etiquette for all of these AO webinar sessions. All of your microphones and cameras have been turned off and muted, but we do want to be interactive. So there is a Q&A box on the Zoom menu here, and you can pose questions to the faculty during this session, and we will do our best to answer those questions either through the Q&A box or with live discussion amongst the faculty. And the chat box, please don't use that. That's just for our AO faculty to communicate with each other with any potential technical issues. Here's our agenda tonight. I'm going to start here with case 1, evaluation and management. And this is actually going to be looking at epibasilar metacarpal fractures. Dr. Mudgal is going to then discuss Rolando type fractures, and then following Dr. Dutton will be discussing the Bennett type fracture, followed by Heather to give us our therapy perspective on management of these type of patients with these type of injuries. So at the end of this series, you should be able to identify the radiographic indications for the procedure that is being discussed, understand the criteria required for the indication of this procedure, define appropriate surgical anatomy and steps in the execution of the procedure, recognize any possible pitfalls and develop strategies to avoid them and to deal with them should they arise, and then to be able to review pertinent literature regarding these procedures so you are most appropriately prepared for management of your patients. This is a review of the sessions that have been completed already. We have 3 more sessions before the end of the year listed here. October 17th, Dr. Harry Hoyen is the sage on nerve injuries, repair and reconstruction. In November, Dr. Jesse Jupiter on distal humerus fractures. And then finishing the year, Dr. Lee Osterman in December on compressive neuropathies. Here's a way to register for all of these type of sessions, and then other AO offerings such as our upcoming webinar on December 4th regarding distal radius malunions. And you can scan that code if you have interest in registering for it, or do it through the AO North America webpage. Other upcoming courses in Cincinnati, Ohio, in the beginning of November, we have a few spots left open for the upper extremity trauma and flap course, a cadaver-based study, November 7th through 9th. And then in February, in Dr. Dutton's hometown here, a hand and wrist fracture management course. Finally, all of these sessions are recorded And roughly 24 hours after the completion of these sessions, you will have access to view them again because of such high quality stuff we'll be presenting through the AO North America webpage through YouTube. And also welcome to those who are participating through OrthoTV in India, where this is also being streamed live. So with that, we're going to start. I'm going to present thumb metacarpal epibasilar fractures. Our objectives here, similar to what we've discussed previously, is that by the end of the session, you should be able to describe the relevant anatomy and deforming forces that impact fractures of the base of the thumb metacarpal, discuss the rationale for operative and non-operative management of these epibasilar fractures, and then be able to apply techniques for closed, percutaneous, and open management of these injuries. So this is what we're going to cover all in all for this evening. These complete articular, partial articular, and extra articular fractures of the thumb metacarpal base. And for this first session, we are going to be discussing these two fractures on the right, these extra articular epibasilar fractures. And we're going to start by showing you 3 x-rays of 3 patients of mine that underwent different paths of treatment. And we'll get back to these cases in a few minutes. So 80% of all thumb fractures involve the metacarpal base, and these extra-articular fractures, these epibasilar fractures, are more frequent than the intra-articular components that Drs. Mudgal and Dutton will be discussing shortly. It typically is the result of an axial load and some degree of palmar flexion through the thumb CMC joint. Typically, plain radiographs are needed to make this diagnosis, but advanced imaging can be considered if more information is needed regarding articular surface alignment, perhaps concomitant trapezium injuries or other carpal injuries. Oftentimes, a traction view may also be helpful to evaluate the degree of articular injury. This classification and system has been proposed for these thumb metacarpal base fractures. And again, we are going to review these extra articular fractures, primarily the 3A and 3B transverse and oblique fractures in adults. So important to understand the deforming forces on all of these fractures, whether they're intra-articular or extra-articular. The abductor pollicis longus, the flexor pollicis brevis, the abductor pollicis brevis, and the adductor pollicis. And if you understand the insertion and origin of these muscles, you will understand the type of forces that they will apply to these metacarpal fractures. And then the one constant force that is certainly more applicable to some of these partial articular fractures is this palmar beak ligament, which we will discuss more in detail with Dr. Dutton's discussion. So with the understanding of what the deforming forces are, then you have an understanding of what the appropriate reduction maneuver is. And typically this is some degree of traction, palmar abduction, pronation, particularly if there is joint instability or joint dislocation, and then some degree of radial extension, and diagrammed here with this picture here. If there is an extra-articular fracture, such as the ones that we're discussing in this particular session, you probably don't need the pronation component. It's more just extension and palmar abduction to realign our fracture fragments. And we have multiple different treatment options for these injuries. They can be managed closed reduction and pinning, or open reduction and internal fixation. So typically fractures that are amenable to closed management are ones that have less than 30 degrees of apex dorsal angulation after reduction. And you want to immobilize these patients in some degree of CMC joint abduction, extension, and pronation, certainly if there is a articular component. But as this diagram on the right shows, you want to make sure that you are avoiding putting the MP joint into full extension or certainly any hyperextension, because that is a surefire way to have the patient develop extension contracture or hyperextension instability. So the image on the left, allowing the thumb MP joint to slightly flex while immobilized, is important for dealing with all types of CMC pathology, even after doing your CMC joint arthroplasties. Closed reduction and pinning is typically appropriate for patients that have unstable and comminuted fractures that are not acceptably reduced. And then open reduction and internal plate fixation for these extra-articular fractures are typically reserved in the state of malunion or impending malunion, where an open osteolysis needs to be done in those delayed presentation, or if there is an associated complex soft tissue injury such that bony stability is necessary before managing the soft tissue envelope. With closed adduction and pinning, for these extra-articular fractures, oftentimes a good idea to have at least one of these pins across the CMC joint, as you can see demonstrated in this picture, with one pin remaining just in the fracture fragment itself and one going across the CMC joint. But with any pins crossing over a joint like this, you want to make sure that they are of sufficient caliber so that they do not bend or break. In these adults, I typically use a 0.054 inch Kirschner wire or a 0.062 inch Kirschner wire. Pins for me are left outside of the skin. I think they're easier to care for, but I leave my patients immobilized while the pins are there so they don't have to worry about pin care. And the pins are typically removed in the 5 to 6 week range based on X-ray image of fracture healing, and then gently allowing them to progress with range of motion and pinch. For those that need open reduction and internal fixation, you have multiple different approaches. A dorsal approach, as demonstrated on the top, being aware of the radial sensory nerves, or a volar radial Wagner approach that might give you better direct visualization of your articular fracture if there is one. Certainly, again, importance to pay attention to the radial sensory nerve branches. If you are going to place a plate in dorsally, then this is going to be underneath the extensor pollicis brevis tendon, so making sure that that tendon has room to glide. And then the benefit of plate fixation is that you don't need to immobilize them as long, and you should be able to get them going into an early range of motion program. Outcomes for these extra-articular fractures are typically related to the quality of the reduction. Because these are extra-articular fractures, this is not likely to result in direct CMC arthritis, but leaving a fracture malreduced with significant flexion deformity, which is the typical deformity, may alter force transmission across the CMC joint and indirectly result in CMC arthritis later in life. So we'll go back to these 3 cases. This is an adult patient with an extra-articular obliquely oriented fracture. Because of the obliquity, we thought that this was going to be an unstable fracture pattern, and with the APL insertion causing significant deformity force across that fracture line. So this is a patient that we took to the operating room with closed reduction and percutaneous pinning. Here's the patient at about 5 weeks before pins are removed, with good evidence of early fracture healing. Case number 2 is a juvenile patient who is in a juvenile detention center who had this fracture, was reduced in the emergency room, but he subsequently removed his splint and was lost to follow-up, presenting 4 months later with this malunion, apex dorsal malunion of the thumb metacarpal base. Taken to the operating room, you can see the central image there with our planned osteotomy for a closing wedge osteotomy to realign this fracture, and then the ultimate plate fixation, followed by his 3-month follow-up radiographs. And finally, this 16-year-old high school football player who injured his thumb in preseason training, minimally displaced extra-articular fracture, seen early, placed into a cast. Here he is at 5 weeks after injury. And then just earlier this week, I saw him back now 9 weeks after injury, fully participating in football activities. So thank you very much for your participation in this session. And as we turn it over to Dr. Mudgal, do we have any questions that we need to discuss? Or I'm sorry, Dr. Dutton, or no, Dr. Mudgal is going next. Yeah. Any questions that we need to discuss?
You know, that was excellent, Kevin. The thing that I would say is, you know, we have these guidelines about 25 to 30 degrees apex dorsal, and we use those as lines drawn in the sand to decide whether to intervene or not. I would say I would probably add a couple caveats to that. And one is that if the patient is older, I think your ability to accept a little greater deformity is higher. And the second thing is, it's best not to go by clinical deformities, because when patients are large boned or large bodied, even 25, 30 degrees can be hidden very easily by the amount of soft tissue around the base of the thumb. So it's very important not to go by clinical deformity, but to go by radiographic deformity. And the clinical deformity will manifest itself later as hyperextension of the MP joint. And then it's a little, then you're in osteotomy territory.
Yeah. Well, all excellent advice from our sage here on the faculty. Okay, Chai, all yours.
Okay, so I'm going to be talking about this. And that's our problem. Kevin talked about epibasilar fractures, and this is the problem that I'm going to be talking about, which is a comminuted intra-articular fracture of the base of the first metacarpal. As you can see, there's fairly large chunks of bone there. And let's see if I can get this to move. So we are going to talk about the Rolando fracture. As part of AO faculty, we receive stipends for educational participation. So what are the goals of today's session for me? I want everyone to understand the nature of the Rolando injury and how we contemporarily define it and what was it actually defined as by Silvio Rolando. You want to be able to evaluate fracture geometry with adjuvant imaging. Familiarize yourself with treatment options in resource-limited environments and in resource-rich environments. And finally, I'm hoping that our audience can actually, after I finish speaking, be able to plan and execute plate fixation as well as external fixation as necessary. Most of the material is mine, but I have liberally utilized from the AONA archives. And while I am AONA faculty and AO faculty, I really have no commitment to this book other than saying that it's a fantastic resource. And if possible, please have your libraries invest in it. So what's a Rolando fracture? This is a classic article from Silvio Rolando when he described it in 1910, and it was translated by Roy Mills and published in CORR in 2006. And the way he described it was an articular fracture of the first metacarpal base with a T or a Y-shaped pattern involving the coronal plane and the volar fragment being what we would call the Bennett fragment. And he surmised that it was a result of axial overload and metacarpal flexion leading to splitting of the articular surface. Contemporary definitions include the figure shown on the extreme right, which is any comminuted fracture of the base of the first metacarpal is considered a Rolando fracture. So how do we assess them? As Kevin alluded to it, getting orthogonal views is important. But for those of you who are early in your training, it's important to know that the thumb is offset from the hand by about 45 degrees. Therefore, a PA view of the hand will give you almost an oblique / lateral of the thumb, whereas a PA view of the thumb will give you a lateral of the hand. And having that concept in your head is very important. If you want a true lateral of the thumb, your hand must be pronated 20 degrees. Finally, a traction view in resource-limited environments is probably as good as a CT scan if you can get a CT. I do get a CT on most of these. So what are my aims of treatment? I like to restore the articular surface, maintain length, eliminate any residual epibasilar angulation, and most importantly, maintain width of the first web space. So what are the choices of treatment? Well, we have non-operative always, but again, it's rare in patients who are moribund or have so many comorbidities that surgery would actually put them at risk. Open reduction internal fixation for fragments which are large, external fixation when fragments are very small, and you can use either combination of ORIF plus XFix and bone graft as needed. So let's look at each of these. The surgical exposures, most commonly, you can use the dorsal approach. The dorsal approach is good, provided your fragments are large and you can see them and you're planning to put a plate. But if your fragments are multiple and small, the Wagner approach, or the classically described by Gedda and Mober, as shown here, is the better approach because you can see the entire articular surface much better. Dorsally, you want to be careful about the cutaneous nerves. And finally, you also want to be careful about the radial artery as it runs across the STT joint. The exposure to the Rolando fracture with the dorsal approach is pretty good, provided your fragments are large, as seen in the picture on the top left. But the only thing is you have to remember, you have to grasp the fragments, and you actually have to make a subluxing maneuver to visualize the entire articular surface, paying heed to the volar beak ligament. So let's look at open reduction. Usually we use a 2 millimeter plate, and you can either use a LCP or an LCDCP. And the point being, you want to convert a multi-part fracture to a two-part fracture. And how do you do that? You get your articular surface back together, number one. And if it's a T pattern, you can get it with the help of a pointed reduction clamp and neutralize it with a wire and replace that wire with a screw. Or if it's a Y pattern, then what you do is you reattach the shaft to the volar beak fragment and then reassemble the dorsal fragment on top of it as shown here. This is one of the few indications for me to use locking plates in the hand. Otherwise, I do not think locking plates are absolutely necessary in the hand, but it's worth looking at them in this situation. Now, just because you have locking plates available doesn't mean they're going to do all the work. You have to work them. And how do you work them? You have to bend them to manage the contour of the proximal metacarpal, which is curved. So you have to bend them accordingly, either with benders or with these pliers. But be mindful that if you're using locking plates, then your bending has to occur in between the holes, because if you bend through the locking hole, it's not going to work. Secondly, you have to also remember that in the longitudinal plane, the proximal end of the metacarpal has a slight curve. Therefore, your plate also has to be bent in that direction to lie flush on the metacarpal. Now, after you've done that, you then attach the plate to the shaft fragment also, and you can see the screws number 1 and 2. If you're using non-locking screws, which in young healthy bone is a great option, it is perfectly reasonable to use. I would suggest that you not tighten one screw fully and then put the other screw. What that will do is it will kick your plate off and impart a torque, which is hard to come back from. I put both the screws in at the same time, and I tighten them a few turns at a time so that the plate sits flush and there's no torque on the fragment. Now, I have no idea why that happened. Okay. As shown here. And then you fix your shaft screws. So here's a patient who's a 30-year-old male, his left thumb. This looks almost like an epibasilar fracture, but if you look here at this picture on the left, you can see the fractures extending into the base. And this was actually an undisplaced Rolando. And so we utilize the same technique that I described before, and you can see the fracture line here running into the base. Oftentimes, the central hole of the T-shaped plate, by design, seems to sit right where the fracture's at. And so it often goes unfilled. But you can oftentimes utilize it by directing your screw away into one fragment and still getting one more point of fixation. And here he is, and you can get predictably good outcomes because I start moving them just about in 5 to 7 days. Another patient who's 45, female, the same exact technique, same exact principles, and again, you can get predictably good reduction and fixation. How about someone like this who has an extremely comminuted fracture and was unwilling to consider an external fixation? So it forced my hand into opening this, restoring the articular surface, and we fixed it with K-wires. Now, is this adequate? Probably not. So I had to maintain length by using longitudinal K-wires, and I maintained him in a cast for about 6 weeks before pulling all the pins and starting him in rehab. Again, reasonable outcome. How about skeletal traction? If you're in a resource-limited environment, this old technique of Thorin, which was published by Breen and Jupiter a while ago, is a good technique to know. You put a K-wire through the metacarpal to emerge in the web space. You put a curvature on the wire, and you attach it to a rubber band, which is then attached to an outrigger on a cast. It's a good technique, works well in resource-limited environments. How about X-fix and internal fixation? Utilized for extremely comminuted fractures, or if there's soft tissue injury, because you want to maintain your length and web space or neutralize an internal fixation construct. What does it neutralize? Well, there's rotational forces, there's bending forces from the adductor, and the axial compression forces. And you have to maintain the first web space. So that's where you have to consider this. Why do we need to maintain the first web space? For obvious reasons, to be able to grasp, to take care of soft tissues, help with wound care, and it also allows you sequential reduction maneuvers if necessary. Now, your external fixation constructs can be of two types. The more common one that is popular is this one shown here, where you put 2 pins in the trapezium, 2 pins in the metacarpal, and then you apply a small or mini distractor. What if you don't have a mini distractor? As you can see in this picture here, the green arrow is to a small distraction clamp, which is available in these sets. And you can even use that instead of a mini distractor. Once you've done your distraction and you think you've got your length back, the next order of business is to tamp down the articular surface and restore it as shown in this picture. Then the next step is to graft it. After you grafted it, it is time to switch your distractor and put your external fixator clamps and bar on before you take off your distractor. And finally, if you feel the need to add more internal fixation, You can either add K-wires as shown here, or you can even add a plate as shown in this case. The external fixator, if possible, should be left there because it helps to neutralize all the forces we just talked about. The other construct is this one, which was popularized by Uli Buchler back in 1991, where you put 2 pins in the second metacarpal, 2 pins in the first metacarpal, bring the metacarpals out to length, and then connect them either with a triangular frame or with a quadrilateral frame. So here's this patient of mine who was a motorcyclist who came off at high speed. And in him, we used K-wires to reconstruct the articular surface. We grafted him and put him into this diamond construct, which we maintained for about 6 weeks before pulling all the pins and the X-fix. And there's his outcome at about 3.5 to 4 months. How much do I immobilize them? I usually keep them if I've used pins or an X-fix in a thumb spica cast or splint. If I use a plate, then I, of course, just use a splint. Early edema control and range of motion of the IP joint is very important. You don't want the IP joint to get stiff. I take out the X-fix and the wires by about 6 weeks, and then I put them in a small orthoplast splint and start range of motion. I start strengthening at about another 4 to 6 weeks, and I discard the splinting altogether. What do the outcomes tell us? Well, the data available for Rolando's is very little. There are very few series with less than 15 cases each. And what they found, not surprisingly, that X-ray outcome equals reduction quality. Only one study looked effectively at grip strength and pin strength. That's Buchler's study from 30 years ago. And they found that it is about 80 to 90% of the opposite side. Long-term studies, which are only about 7 to 10 years out, have seen that there's a radiographic appearance of degeneration in almost 3/4 of the patients. But here's the kicker. Clinical outcomes do not mirror radiographic outcomes. So with that being said, I'm going to stop here and hand it off to Kevin and Lauren.
Shy, thanks so much. What a great and comprehensive presentation. So good that we have no questions from our participants. But very eloquently presented with lots of different options of treatment there, from your external fixation designs to the very nicely done plate fixation. So thank you very much.
Sure. Either our audience is bored to tears or they are stunned into silence, one of the two.
All yours, Lauren.
All right.
There you go.
Thank you. I didn't do it in the proper order where I unmuted and pulled up my slides, but hopefully everyone can hear me. Good evening from Jacksonville, Florida. My name is Lauren Dutton. It's an honor to be here with you. And in particular, it's been wonderful to work with Dr. Mudgal, who is a mentor of mine in residency. So it's been very fun getting to reconnect with him on this presentation. So without further ado, I'm going to speak with you about Bennett fractures today. We're going to talk about what a Bennett fracture is, how it got its name. We'll discuss the rationale for operative, non-operative treatment, and then go through some techniques for kind of the mainstay for treatment of this injury, which is closed reduction and pinning. So in the words of Dr. Mudgal, the case that I'm going to present is that of a 25-year-old right-hand dominant young male who had an unfortunate encounter with the road after his hand hit it after a motorcycle accident. To give you some context, this is one of the first cases I did as an attending. I was a general orthopedic surgeon right out of residency, moved to Beaufort, South Carolina for my first duty station, and this was one of the first cases I saw. So I wouldn't be surprised if I actually did call Dr. Mudgal about this case. But let's kind of flash back to 2016 when I saw this injury. And so Dr. Mudgal, if you would, if I were to send you these x-rays and say, what do I do with this case? I'd love to hear, first of all, and this was copied from one of my co-fellows. She used Gandalf and I've settled on Dumbledore. As our sage, could you first start off by telling me what further imaging you might find beneficial, and then what's your sort of initial treatment plan and thoughts about this case? I'll go back to the x-rays.
So when you look at these radiographs, it is tempting to think that this is essentially completely undisplaced. And it is also tempting to think that you can effectively manage it in a short arm cast or a splint. And as Kevin told us, the number of deforming forces are quite significant. So the first thing I would say is, if possible, try not to make that judgment call based on these radiographs. If possible, please get a CT. And if you cannot get a CT, at least get a traction view. And you can get a good effective traction view by instilling lidocaine into the CMC joint so that the patient doesn't get pain, and get a good traction view so you get a sense of fracture geometry. So that's what I would do. If possible, get a CT. And initial treatment options, well, now, close reduction and casting. Now, this is an important thing to show, because it is very hard to close, reduce, and cast these. And if you look on the X-ray on the left, what you're going to see is that the MP joint is extended. And the important thing to understand is when you're reducing these, you're holding the thumb right at the base of the web space, and you're putting all the extension force on the MP joint. And Kevin mentioned this. It is really important to make sure that the extension force is on the head and neck of the metacarpal, while the pressure force is at the base of the metacarpal. Only then can you get an effective reduction maneuver. Otherwise, you might end up with extension contracture, as Kevin alluded to. Now, is this adequate? No, I think there's an element of flexion in that joint there. So I would not be content with accepting this reduction, to be honest.
Oh, very well. So I performed a closed reduction. I obtained a CT scan. And, I think the images that we can see here kind of indicate, as you were mentioning, it's not the most, I think it looks much more benign and innocent on the radiographs than it does on the CT scan here. So we can clearly see the intra-articular component and the so-called Bennett fragment, which we'll talk about in a moment. I got the 3D renderings of this metacarpal fracture as well, and kind of nicely seen here. This is a little bit of a funny photo, I know, but the volar side is up here. So it's this volar ulnar fragment. So this is indeed a Bennett fracture. This is a partial articular fracture of the base of the first metacarpal. And it was described appropriately by Dr. Edward Bennett. He was an Irish surgeon. And as Dr. Mudgal did, I always find it interesting to go back to the original text. So in this case, it was the British Medical Journal in 1886. And first of all, he talked for a while about initially he only saw these fractures in right hands and wondered if this was just a phenomenon that somehow spared the left hand. But he reported that he actually eventually found a couple of left hands. And he talked about the features of this fracture. So an oblique fracture, and the majority of the metacarpal displaces or is displaced proximally, radially, and dorsally. And then the small constant, or as it came to be known, the Bennett fragment remained in place. Now, why does that happen? Similar picture here to what Dr. Malone showed. Originally thought to be this palmar oblique ligament. From what I understand, more recent anatomic dissections have suggested that perhaps the ulnar collateral ligament could also be holding this in place. But for whatever reason, this small Bennett or constant or volar ulnar fragment stays in place, whereas the rest of the metacarpal bone is pulled dorsally, proximally, and radially, such that it effectively becomes a subluxation. So this is a fracture, subluxation, or dislocation. So back to Dr. Mudgal, what's the next right thing to do here? And I have a litany of questions that I would like to ask you. And I didn't want to just use Lord of the Rings and Harry Potter, so I have a plant sage, and then of course our wise sage Taylor Swift as other examples of sages who might be able to help us. So if you could kind of take us through the nuts and bolts of this, how would you pin this? Do you pin straight through the skin? Do you make a small incision to try to avoid irritating the nerve? How many pins are you using? Are you burying them? Please, if you would, just kind of get into the brass tacks of this.
Can you go back to the previous picture? Oh, okay.
This one.
Next thing, yes, okay. So, and I see that I've been equated to Taylor Swift. Next slide, please. Yeah, I mean, I don't know if Taylor Swift is everyone's cup of tea, but then haters gonna hate. What can you do? So, um, now, if you the most important thing that you said in what you just said before, and which sometimes get lost, we talk about Bennett's as a fracture. True, it is a fracture, but that is not what undoes the CMC. It's the subluxation that undoes the CMC. So, for me, the treatment of the Bennett is not so much the treatment of the fracture fragment and articular restoration. Of course, they are. But the real treatment is making sure that the joint does not sublux, because subluxation destroys the joint a lot faster than a 1 millimeter step. That much we can agree on. So for me, all my emphasis is not only on trying to get the joint back together if possible, but I want to make sure I reduce the subluxation. That is the real key. What are my techniques for pinning? Well, there are multiple techniques described, and you can use the old technique described by Wagner, where he just went from the metacarpal straight through into trapezium. Or you can use the Iselin technique, which is intermetacarpal wiring. And the only difference with the Iselin technique is that instead of going from metacarpal 1 to 2, you go that 1 to 2 in one direction, and you come from 2 to 1 in the other direction. And you put curves on both ends. Supposedly gives better fixation. I've never used it. You can also use a combination of the Wagner and the Iselin, where you put one wire from the metacarpal 1 into the trapezium, and the second one from the metacarpal 1 to base of metacarpal 2. Now you have to be careful with that, because if you come too close to the base and your wire trajectory is off, you have to be mindful that the radial artery dives down to the volar side, right there at the base of the first web space. You have to be careful of that. Secondly, the trajectory of your pin that goes into the trapezium, you have to be mindful that you remember that your carpus has an arc. So if your wire is spouting out too far and it is volar, you can easily impale structures within the carpal tunnel. And there are case reports which allude to median nerve impalement. So you have to be mindful of the carpal geometry as well. I do them closed. I don't make an incision. And the thing that I tell all my trainees is you have to remember the shape of the metacarpal is an arch. So rather than put it on the top of on the apex of the arch, I come to the sides. I start the pin at right angles, and as it's spinning, I redirect it so that it doesn't keep skiving off. I usually use 0.062 inch wires times 2, which is 1.6 millimeters. And I leave them out of the skin. I put a bend on them. I don't put any Jurgen balls or anything, any stuff on them. And that's really my preferred technique, paying great attention to the reduction maneuver of traction, pressure, and pronation. And also, if I'm going to use intermetacarpal pins, you have to, or even if you're using just trapezial pins, make sure that your thumb is abducted and your first web space is open when you put that pin in. It's very common to feel like you have to bring the thumb in close as you're doing the reduction maneuver, but try not to do that. Make sure your thumb is completely widely open. When do I open it? Not very commonly, but if I feel like I can't get control or if the fragment is completely turned, sure. And then I'll use the Gedda and Moberg or the Wagner, whichever name you call it by approach, elevate all the abductor, the flexor and the opponent's pollicis and sweep them off the base of the metacarpal. And then you're looking bang down at the base of the metacarpal. You incise the base, the capsule, very carefully because you don't want to injure the volar ulnar corner. What do you do after this? Well, you can either fix it with pins under vision, or if you feel enthusiastic, you can put screws in it. You can, to be honest, data has not shown the superiority of screws over pins. It looks nicer on the X-ray, but other than that, it doesn't do much. So, how long do I leave the pins in place? If I have the pins, 6 weeks. And I see them back. If I made an incision, I'll have them come in for stitch removal. When I transition them from a post-op splint to a cast, in the cast, I'll leave the IP joint free and I'll start the IP joint moving right away. Other than that, I usually will see them only directly at 6 weeks. If there's any concern that the cast might get loose or I'm concerned about the mentation of the patient, then i.e. if they're knucklehead, then I will call them back a little sooner to change the cast as well as make sure the pins are okay.
Perfect. Okay, thank you. So that's what I did. I did a closed reduction and pinning. You talked very eloquently about the reduction maneuver, and then I, as you can see, put a pin from the first metacarpal base into the trapezium, and then one from the first into the second. Thank you, Dr. Mudgal, for previously bringing to my attention this study by John Capo. This was from JHS 2009. Perhaps we are not getting the reductions that we think that we are when we are just using fluoroscopic imaging. So this was a neat study in which they had 8 cadavers in which they created Bennett fractures, reduced them, pinned them under fluoro, obtained what they deemed to be an adequate reduction, and then reassessed them in 2 different ways. They got plain films, and then they also opened them up, dissected them, and actually directly measured the articular step off and displacement, and found that indeed both x-rays and direct measurement demonstrated significantly increased step off and displacement. What to do with this? It's hard to say. Should we be getting plain films in the operating room before we leave? Dr. Mudgal, any thoughts on that?
So the John study is a very nice study, the one that you just shown here. And people might say it's an older study and we've come a long way since then. But a more recent study from Jishutan Hospital in Beijing, done by one of my old friends, Yen Yaobin, they also looked at the same exact thing. And they concluded the same exact thing that John Capo's study concluded, in that fluoroscopy is not as great as you think. That's one side of the coin. The other side of the coin is, does it matter? If your fluoroscopic step, let's say there's a step, is not humongous, i.e. you think it's going to be 1 millimeter or 2 and half a cortical displacement, does it really matter? Because long-term, i.e. 7 to 10-year data that's available seems to suggest that as long as the articular step is not more than 2 millimeters, it doesn't seem to affect radiographic outcome. And like I said before, much as it happens for Rolando fractures, for Bennett fractures also, radiographic outcomes do not seem to follow clinical outcomes. So, like I said, again, all these studies have been zoned in on articular reduction and fragment reduction. But none of these studies have focused on quality of reduction of the joint, i.e. was the joint subluxed or not, and what did the subluxation do to your long-term outcome? I think the key will lie there.
Fantastic, thank you. So just a quick run through. I saw him back at 2 weeks, transitioned him to a cast. Again, this was done in 2016. I removed the pins at 4 weeks. I'm not sure why. I'll give you the opportunity to potentially criticize that in a little bit. And then I put him into a thumb spica cast to protect him for 2 additional weeks. This was an active duty patient. I saw him back at the 2-month mark. He was doing great, had regained his range of motion and was ready to deploy. So I'd love your feedback. Did I take the pins out too early? What is an appropriate time? I know you mentioned for your Rolando fractures, you like to keep them in for 6 weeks. Is 4 to 6 weeks good? How do you judge when they're ready to come out? I think we kind of hit on these, should this have been fixed at all? I think when I first showed you this, I said, well, maybe I shouldn't have fixed it. It wasn't, it wasn't truly subluxated. And you said you just didn't give it enough time to become subluxated, but that was probably the way it was going with the pull of the APL on it. And then we talked a little bit about, I'd love to hear your thoughts on once the pins come out, if you let them go or put them into a splint. And then we have our hand therapist at the end, Heather, who can speak to the rehab after the pins are removed. So
the pins coming out too early. Now, if you took the pins out at 2 weeks and 3 weeks, I would say, yeah, maybe that's too early. At 4 weeks, I think you're reasonably safe. 4 to 6 weeks, because everyone can, so pins can become loose for lots of reasons. And oftentimes when we say the pins have to be kept in for 6 weeks, we think of it as a line drawn in the sand. It's not. I think 4 weeks is adequate as long as you don't start moving the patient at 4 weeks. If the pins come out at 4 weeks, for whatever reason, either volitionally or non-volitionally, then as long as you can keep the patient quiet in a cast or a splint, and splint if they're reliable, in a cast if they're not reliable, for another 2 weeks, I think you're fine. And should it have been fixed at all? I think if you look at your original X-rays, what you'll see is there is a subtle flexion at the base. And that subtle flexion at the base, go back, even that CT shows it. There's subtle flexion at the base. And that is telling, that's exactly what I was alluding to when I said, give it time, it will slide. So that's what I was alluding to. Once there's subtle flexion at the base, no matter how your fragment looks, like I said, this is a fracture subluxation. We got to pay heed to the subluxation.
Perfect. Just two additional cases provided by Dr. Mudgal and Dr. Jupiter, a little bit more clear-cut examples of Bennett fractures. The example that you previously discussed of one option for pinning is just placing 2 pins from the first metacarpal base into the trapezium. And then the option to use as well, which look great. And thank you for previously having kind of taken us through how you perform an open reduction and screw fixation. Quick slide on outcomes.
Go back to
the
that,
good news is,
go back to that X-ray,
yes,
Lauren.
yes.
This X-ray highlights to you exactly what I'm alluding to. See the degree of subluxation of the metacarpal base. And that is exactly what I was talking about. We are talking about fracture fragments, but no, it's the subluxation that will do you in every time if you don't pay attention to it.
Good news is people do very well after closed reduction and percutaneous pinning. The first study is a nice study that was done in 2021, and they did both an 11-year retrospective cohort analysis of their own patients, of which there were 49 with a mean follow-up of 17 weeks, and most regained full range of motion. I think it was Kapanji scores 9 and above, low complication rate and happy patients. And then they also did a systematic review to look at long-term outcomes and found high patient satisfaction, low DASH scores, and so concluded that CRPP is sort of the gold standard for Bennett fractures. The other study is a longer-term look from the Bone and Joint Journal at follow-up of patients who underwent CRPP for Bennett fractures at a mean follow-up of 11 and a half years. And again, high patient satisfaction, low DASH scores. So these are my take-home points. I think Dr. Malone, Dr. Mudgal, and hopefully this presentation have talked to you about the deforming forces and how you can mitigate and try to overcome them. General indications for a Bennett fracture, you know, we can talk about the step-off and the angulation and such, but I think Dr. Mudgal did a really nice job of explaining to us how this is an unstable fracture and deserves to be treated as such. And so there should be a very low threshold to stabilize these. We didn't specifically get into this, but if you have that Bennett or that constant or that volar ulnar fragment, and it's pretty small, you know, I don't try to capture it with a pin. I just am happy if I can reduce the joint, because as Dr. Mudgal alluded to multiple times, the main thing that we are treating here is the joint, and we want a congruent concentric joint. And then, you know, sometimes cases like these are great to discuss because some, you know, our x-rays are black and white, and a lot of people think orthopedic surgery is just, you know, the bone is broken, fix it. But sometimes there are some gray areas, and the optimal management for your patient, and not just the x-rays that are taken of them, is something that is really fun and interesting and important to think about. And as such, I think it's very important to always have a wise sage who is available to you on speed dial. So thank you so much for listening, and I appreciate your time.
Lauren, great talk, great presentation, interaction with Chai as well. We do have 2 questions for you from our audience. So one asked about post-op x-rays that you get with following your Bennett fracture after surgery. Dr. Mudgal talked about the different imaging studies, and while he didn't name the study by eponym, the PA of the thumb or the Roberts view, is that something that you think is important to get as you're following these patients? You didn't show that on your presentation.
No, it's a good question. I think important for diagnosis of the fracture in terms of the postoperative follow-up and whether I'd want them, especially with the pins in, to be manipulating their hand that much, I'm not so sure. So I just a standard 3 view of the thumbs. I may have mentioned I did this case before hand fellowship. I probably didn't know what a Roberts view was, so I did not focus on obtaining that. But I'm curious to know if you two specifically try to obtain that view.
I can tell you, as Chai alluded to the importance of joint subluxation, you're not going to see that as well in the direction that these joints sublux on a Roberts view. So it's really that lateral orthogonal view that's going to give you the subluxation, the pull of the APL. I think is perhaps more important after you got everything lined up and reduced. But that Roberts view is certainly a very critical view, and you all should know how to obtain that or be able to teach your X-ray techs on how to do that. It's a hyperpronated PA view to bring that joint in plane. That's going to really show the joint space, maybe in some cases more appropriate for the arthritic patient that you're seeing. And then, I guess for both of you with your articular fractures, how many of the joints do you recommend immobilization for after you have stabilized these? Particularly, I guess, the pinning patients, because if you're going to plate fixation, you're going to get them moving early. But with the ones that are pinned, are you going to immobilize the MP and IP joint as well in their immobilization, or just try to focus on the CMC joint and the wrist?
So for me, I don't think the IP joint needs to be immobilized at all, because if nothing else, it allows the patients to start getting functional even while they're in a cast. Let's say there's someone who likes to type or write. We live in a pronated world, right? So people are typing with the thumb all the time, and they can still be effective if the IP joint is free and mobile. Secondly, if they like to write, we have a mobile IP joint. You give them a pen with a fat pen grip on it or a sleeve on it, and they can still write. So having an IP joint mobile, to me, makes the patient a lot more functional right away. So that's I don't try to immobilize the IP joint at all. Can you get away by just immobilizing the CMC joint? I think you probably could, provided you had stable fixation, but I'm not going to trust someone with that. So for me, immobilizing the wrist is really important.
I agree. All right. Thank you very much. Heather, we'll turn it over to you.
Great. Thank you so much. Let me go ahead and share my screen.
Kevin, while Heather is pulling that up, we have a few other questions, and if you can choose and decide which ones to answer later.
Yep, I'm looking at them and answering some of them on the Q&A, but we can bring some up to the panel here at the end.
You bet.
Great. Okay, hi everybody. My name is Heather and I'm a certified hand therapist. I work at University of Vermont Medical Center, and I'll be speaking with you all regarding fractures at the base of the thumb and rehabilitation for those fractures. So objectives for today are to identify what are the common complications after we see these base of thumb fractures, and then also comparing treatment protocols for operative versus non-operative fixation. How do those compare? What do they look like? Also explaining rehabilitation techniques that we use in order to treat those common complications that therapists typically see following base of thumb fractures. So according to the literature, your thumb is very important. Your thumb really provides up to 40% of your hand function, and complete loss of that thumb can lead to a loss of 22% of bodily function. And that's huge. And I do see that on a clinical basis, where many patients will come to me and say, wow, I guess I never realized how important my thumb is in the use of my hand. The interesting thing about the thumb is that it does have a tendency to compensate for stiffness, which can be a little bit of a double-edged sword, because on one hand, if you're looking at more of just getting someone functional, it can be great where one joint can compensate for another joint's stiffness. However, if you're trying to get range of motion back in a certain joint, it can be a little bit more of a challenge, because that person will tend to cheat with a joint that's maybe a little bit less stiff. Bennett fractures are seen a lot more commonly than Rolando fractures, as well as, epibasilar fractures as well. I can certainly see that clinically, where we see Bennett fractures and epibasilar fractures a lot more common than a Rolando fracture. And to be honest with you, rehabilitation is generally fairly straightforward, which is great. And I've polled a lot of the other therapists in the clinic that I work with saying, do you guys normally see a lot of complications? Because I know in my personal practice, I don't see a lot of those issues coming through, or, it's not something that it's as dynamic as maybe a flexor tendon repair or something like that. And the consensus is that generally these are pretty straightforward. So here's the protocols that we typically follow when it comes to casting versus K-wire fixation and open reduction and internal fixation. In our clinic, usually they're casted for about 6 weeks. Then we get pulled out of the cast and then go ahead and start them in a forearm-based thumb spica with the IP joint that is free. And similar to what Dr. Mudgal was saying, a lot of patients do really appreciate that IP joint being free. It's crazy how thankful they are, because a lot of these patients are still trying to work, and many patients are working remotely at home, typing, that kind of thing. So 7-8 weeks, you can start to get a lot more aggressive with your range of motion, get them moving. And the great thing about a custom fabricated forearm-based thumb spica is that you can make that hand-based, which is really important when it comes to eventually that 10 to 12 weeks, resuming that hand normal use, sports, that kind of thing, because while you're not needing that, fixation of the wrist as much once you get to that 10 to 12 weeks, it's not uncommon for our patients to be a little bit sore when it comes to pinch because of the fulcrum of the thumb. A lot of times patients will say, I'm still having a lot of soreness when I go to pinch, because it's such a long lever arm that maybe a little bit of pinch force at the tip equals a lot more at the base. So the cool thing about a hand-based thumb spica is that it can give those joints a little bit more support, especially if somebody comes in with not the most stable MP to begin with. And it can give that joint up a little bit more support so that it can help that base of the thumb. K-wire fixation, open reduction, internal fixation. From a therapist standpoint, we love those in terms that we can get them moving a lot faster, and therapy loves to get people moving because we can, reduce their chance of stiffness. However, then we do battle a little bit with the postoperative swelling, and certainly the scarring and the tendon adhesion that can come along with that. Here's an example of the orthoses that we make at our clinic: left forearm-based thumb spica, and then we can convert that to a hand-based, which you can see on the right side of your screen. So jumping into what are the common complications? What's therapy seeing when rehab is not straightforward? Number one that I think that I see is that beginning of just rumblings where people are talking about arthritis. And I think there's a lot of interesting stuff in the literature about fixation and its correlation to the potential for arthritis. In the literature review that I did, I'm not seeing a straightforward answer for that. So what I was considering is, all right, what can therapy do to help with that chance of arthritis later on? So we'll talk about that in a minute. Also, radial nerve pain. That radial nerve can be really temperamental. I heard a surgeon once say that the radial nerve can't take a joke, and I feel like that's super true. Things can set it off. So swelling, casting that's maybe a little bit too tight, or even the patient gets out and they want to ice it 24/7, and now they've given themselves a little bit of a nerve injury just because they've over aggressively iced it. Adductor shortening. We need to be able to bring our thumb out from our palm in order to functionally use the hand. Dorsal capsule tightness. So maybe they develop this Z deformity where maybe the CMC sits in too much flexion, and then they compensate with this hyperextension of their MP joint. And then suddenly there's a lot more pain. And trying to get them back into CMC extension it's really tough for patients to grasp. And then of course, tendon adhesion as well. So with arthritis, a traditional arthritis is decreased ligamentous stability, maybe proprioception is leading to this, adductor polysis, muscle shortening, and then this hyperextension. But the cool thing is that the literature is showing more and more that this dynamic stability program can really help with that. So it's shown on this page, and it's interesting because traditionally in the literature, they're talking about using this for more people that just come in and say that they have arthritic pain. But what I've started doing is when I have patients that come in and they're ready to start strengthening after a base of thumb fracture, I actually start them on this program. And the reason why is because I find many patients are going to get much stronger, but also more stable with this program. So meaning when people start to use their hand, they're going to start to use it for pinch and grip. Those muscles are going to get strong, but what's not going to get strong is first dorsal interossei, opponent's polysis, the muscles that can give that joint a little bit of extra stability and set it in the right spot. And so these exercises are great because it makes sure that we have this dynamic stability of the thumb and that they're not compensating by over relying on some muscles and ignoring others. So radial nerve, really, this is the kind of things that I listen for when it comes to radial nerve. People will say wearing a glove is painful, or maybe when I go to make a splint or an orthosis, and they're just not sitting comfortable in that. And no matter how many modifications I do, it's just not comfortable. That's kind of a cue for me to look at that radial nerve. It can masquerade as arthritis, which is really interesting. And a lot of arthritis that comes in now, I'm evaluating that radial nerve because sometimes, because it's so close, people will say the word achy, but a nerve can present as achy. So making sure that you screen that out. Burning and tingling is the most, common complaint. And then also pain with functional movements that put that nerve on tension. So things like typing, things like I had a patient winding a clock was painful, washing dishes, going back and forth, tensioning that nerve. Here's how we treat radial nerve irritation in our clinic. We're starting to come more and more into the treatment techniques used by Allison Taylor, which a lot of therapists, that'll probably sound familiar. She hasn't done a lot of research, but her methods have been really helpful for our clinic in particular. So using kinesio tape to kind of help to create a little bit of space, the idea being that sometimes your skin becomes adherent in that scar, and the skin, when you move, especially into flexion, needs to glide distally, the muscle glides proximally, and that nerve sometimes can get caught in the middle somewhere. So making sure that nerve isn't tugging, but rather gliding. We even find that clipping the first web space, yes, it's great for an adductor release, but the other piece of it too is that sometimes it creates a little bit of the slack, and then a painful movement that was happening before is now less painful. Wartenberg's glide is great for a distal nerve impingement versus a traditional radial nerve glide. You can screen out maybe it's proximal or distal in origin, and then also desensitization with, you can see the sensitivity sticks that we have made at the bottom in our clinic. We've also found this new technique coming out more. It's called radial nerve scraping. It sounds a little aggressive, but truly what it is it's myofascial release at common areas where there are angles where that nerve can get kind of tractioned or stretched. So we send people home with a popsicle stick and then tell them to do medial and lateral corridors of the thumb, and then basically the DRSN, the dorsal radial sensory nerve distribution. Other ways to mobilize that scar is going to be Dyson to be able to grab onto it because, so many structures are really, really close to the skin. And so it can be hard to sort of get a grip on that scar in order to mobilize it. We use, the elastomer mold or certainly some sort of silicone to soften that nerve, and then cupping more and more. The cups on the left are great because they really help to pick up that scar, especially if it's adhesed to, it could be anything, EPL tendon, it could be the radial nerve. These, you can get them off of Amazon for like $12, and I've been using them for trigger finger release scars as well, but we've had a lot of success with the cupping in my clinic. And then finally, dorsal capsule tightness. You can build that dynamic splint. I've actually built a dynamic splint not only to help with IP joint flexion, but also with MP joint flexion. So I can, make a splint where I'm getting that CMC into extension and making sure that my sling actually sits just above that metacarpal and brings that down. And then having them work on neuromuscular reeducation, because you ask somebody to go to the small finger, oftentimes they can get there, but it's going to look really messy because they're going to hyperflex down here, and then the MP is just not bending, and that isn't a functional pinch pattern later on. So you can, usually our typical wear schedule is 15 to 30 minutes, maybe a few times a day, but really evaluating what joint is the most stiff. So in summary, there's a lot to look at when it comes to these. A lot of them are straightforward, but when they're not straightforward, then there's a lot to consider. So looking at, op versus non-op, I think as a therapist, if you feel like the fixation needs to happen where it's, it's needing to be done where it's not casted, and you're willing to, we can get them moving faster, that's great. If it's something that is going to be able to be reduced in a cast and that person is going to be able to come out and start moving, at that point, that's awesome as well. The radial nerve is definitely something to be considered when it comes to casting and also therapeutic management of these sorts of things. And then really as a therapist, doing regular self-checks, making sure that that patient is not developing compensatory movement patterns that will build on itself down the road. And then many years later, thinking long-term and thinking about these patients and as their thumb ages and what tasks they're doing, maybe they're repetitively pinching on a factory line, making sure that their thumb has got a stable pinch pattern so that they're well set up for the future, and just maintaining that dynamic stability. And here are my references. Thank you very much.
Heather, thanks so much. A great presentation, and as one of the participants just chimed in, how great it is to have the therapist perspective on these talks, and it's something that we've tried to do for the last couple of years. And for those of you that are new into practice, talk to your therapist. You will learn so much from them on evaluation and management, and really partner with them because you're all on the same team. I want to make one comment, and then I've got one more question for Chai. We can open it up for other comments too. We've got about 10 more minutes before our session is done. Lauren, with your discussion of Bennett fracture, and Chai mentioned these the intermetacarpal pin from the thumb to the index finger metacarpal. I think it's important to be aware, as Chai talked about, the penetration of the K-wires that go through the CMC joint through the trapezium can end up in the carpal tunnel. If you're not careful with that wire from the thumb to the index finger metacarpal, and you're leaving it quite proud on the dorsal ulnar aspect of the index finger metacarpal, you can see these patients back with extensor index ruptures. So making sure that, maybe one cortex there is enough, really being careful not to penetrate that dorsal ulnar cortex of the index finger to metacarpal to avoid your extensor tendon rupture. And then Chai, and I'm saying that from experience because I've seen it. Chai, I think I know what your response is going to be to this based on some of the comments you've made already. These are typically injuries that we see more commonly in younger people, but every once in a while you'll see someone in an older patient who may or may not already have a little bit of CMC joint arthritis. Are you as aggressive at trying to get the joint surface aligned, or again, just focusing on getting the joint reduced, get the mechanical alignment so that if these patients have symptoms later, easier to convert them to some sort of arthroplasty or management of their CMC arthritis, as opposed to going through scar or whatnot that you've already put there because of your attempts at articular alignment?
That's a very good question, especially now as I've gotten older with each year, my definition of older changes. But, the thing is, I think that the frequency of these fractures in the older population is probably a little less, simply because the CMC becomes less mobile as we get older. And one of the reasons the CMC undergoes this fracture dislocation or fracture subluxation is that you need to have bending and axial compression. And if your joint doesn't bend as much and doesn't have the same kind of axial compression, I don't think you get those kind of injuries in the slightly older patient. But if you do get them in the older patient, I think it's perfectly reasonable to attempt to get them right. It doesn't have to be that you say, okay, we have to make it perfect. Just you don't have to make it perfect because you're of a certain age. Clearly, if the patient is 75 or 80 years old, I think your discussion is going to be entirely different. Also, if they are moribund, or if their functional demands from the hand are not huge, then you don't have to go crazy trying to make a picture perfect joint, because you can always address the other side of the joint and do a CMC arthroplasty. But if the person is high functioning, I think it's perfectly reasonable to try to get as good of a radiographic outcome as possible without going crazy.
Thank you. Any other comments? We've answered all our questions. Heather, I want to make sure you have a patient referral on the Q&A list here, so make sure you saw that. This is a great business.
I guess I better get back to work, right? No rest for the.
But
I see
Chai,
that, but
Lauren,
the answer.
yeah.
I can certainly see it. She's asking about osteoarthritis, and we do treat that in my clinic.
Yeah.
Dr. Bess was asking for that, yes.
Chai, Lauren, any closing comments?
It's been a lot of fun. It's good stuff. And I think it's important that we cover this, because oftentimes the thumb doesn't get the kind of importance that it does the base of the thumb. And I'm glad we covered this, and we had a good session. Thank you.
Very good. Well, again, this session will be available on our YouTube channel. So if you want to go back and listen to any of it again, or see these slides, give it 24 hours or so, and you should be able to find this talk. And then be sure to tune in for the remaining 2 sessions before the end of the year. And at the end of the last session, you'll be given an ability to obtain your CME credits. So Thank you to my co-panelists, Dr. Mudgal, Dr. Dutton, and Heather coming up from Burlington, and to the rest of the AO staff that has helped put this together as always. What a great session. Thanks so much, and have a great evening.
Thanks very much.
Thank you.
Abigail, Lauren, Heather, Kevin.
Thank you
Great.
so much.
Thanks so much.
Thanks, everyone.